we do a bit of laryngitis and dysphagia. Then we call it an evening, and then we also call it a goodbye so that you can revise for your exams. Today is our last lesson. So, what are adenoids? Adenoids are the nasopharyngeal tonsils. They're nasopharyngeal tissues. When we open our mouth wide, whatever we see on the throat, the circle that forms there, we can see the tonsils, the palatine tonsils on the sides, both sides. But the adenoids are located just on the junction of the roof and the posterior wall of the nasopharynx. So we cannot visualize adenoids when we open the mouth or through the nose unless we do maybe a posterior, we examine through a nasopharyngeal mirror, or we do an x-ray. That's when we can see the adenoids. Or whatever we see in our nose, we say those are the turbinates. So those are not our adenoids. So the adenoids are nasopharyngeal tissues. We've said their location is at the junction of the roof, the posterior wall of the nasopharynx. They differ with the tonsils in that the tonsils have crypts. Some of our tonsils, when you look at them, they have crypts. Zinakaa ziko na shimo shimo. Those two shimos are what are they called? The crypts. And the adenoids don't have the crypts. And they're all lymphoid tissues. The tonsils are lymphoid tissues, and the adenoids are also lymphoid tissues. So adenoid tissues, one is born with them. They're present at birth, and they tend to enlarge as the child grows, but the enlargement, they enlarge up to around 6 years, but then they tend to atrophy from puberty, and by age 20, we expect that the adenoids have atrophied completely. So we've said they're lymphoid tissues. So where do they drain into? Our adenoids drain into the upper jugular lymph nodes directly, or indirectly, they drain into the retropharyngeal and the parapharyngeal lymph nodes. So we've said they undergo physiological enlargement from the time of birth up to around 6 years in that is still childhood. But in some children, they tend to enlarge excessively. So depending with what the child have, it will either give you, show us that the child will have excessive enlargement of the adenoids to give us symptoms, or not to give us symptoms. So a child with allergy, so they have a history of, or a child with allergy, a child who has history of recurrent attacks of rhinitis, a child who has maybe sinusitis or chronic tonsillitis, then they have recurrent, they can have excessive enlargement of the adenoids. So any allergy of the upper respiratory tract can still lead to enlargement of our adenoids. So these children present in different ways. And the most common one is nasal obstruction. They have the nasal symptoms, they can have the ear symptoms, then they can have the general symptoms. So the nasal symptoms, the most common one is nasal obstruction. Then they'll come with snoring. Because our nose is obstructed, they'll have snoring, and then they also have nasal discharge. So because of the obstruction, the secretions cannot drain into the nasopharynx, so it is draining out. So nasal obstruction and snoring are the most common symptoms. The mother will tell you, my child is having mouth breathing. Mtoto anapumua na mdomo, mapua imefungana kila wakati. That one is the most common symptoms. And then They can also have recurrent attacks of sinusitis. At times, they can have epistaxis when they are acutely inflamed, when the adenoids get acutely inflamed, and then they have nose blowing, so they can cause trauma and have epistaxis. Because of the nasal obstruction, they can have voice change because our nose also helps us in gives us quality of voice. The quality of the voice that we have comes through the nose. So when your nose is blocked, you don't have the same quality of the voice that you have when your nose is not blocked. Either it can be very low or very high. They say hyponasalia or we have nasal blockage, obstruction in the nose. And remember where our eustachian tube is opening, and the eustachian tubes open up in the ear, in the nose, and the throat. So when the eustachian tube is blocked, it can, when you examine the tympanic membrane, because of the same blockage, they will still complain of hearing loss. They complain of hearing loss, especially when you do it, it's the conductive type of hearing loss. And then because of the blockage, still they can get recurrent attacks of acute otitis media because we don't have aeration of this media. Still, we will be exposed to CSOM because of the same. And then at times you also get serous otitis media. And then the child has general symptoms like the adenoid fasces. The adenoid fasces, it is a distinct look. Enye ukiona tu mtoto mouth breathing, and then when you mouth breathe, remember you don't close your mouth, so your teeth are like they're protruding. So they have something known as the adenoid fasces, that conspicuous look. It happens because of the chronic nasal obstruction and mouth breathing. It gives the child a characteristic appearance, and this characteristic appearance is what we call the adenoid fasces. Remember, this child has the open mouth, the teeth are protruding outside. That is what we say are the adenoid fasces. So, we've said the most common symptom here is the nasal obstruction, the snoring, mouth breathing. At times they also have the nasal discharge because of the obstruction. Then they can get conductive hearing loss because of blockage of the eustachian tube. When you look here, this is when we are doing investigations, we will request for X-ray of the postnasal space, and diagnosis lateral X-ray of the postnasal mouth. So this is the mouth into the throat, and now this is the nose. You can see the airway. When it's coming here, it is child also has enlarged tonsils. It is also pressing on the airway. So most of the time, adenoid hypertrophy goes has hand in hand with tonsillar hypertrophy. So when you are examining, you also have to examine the tonsils to check if they are enlarged, meaning they're just big and they are not inflamed. So, this X-ray gives us how the adenoid looks like. You check the airway, how it is it competent or not, and then also for the tonsil, it will push the airway and reduce the size of the airway. So after we've done our X-ray and we've found that the child has adenoid hypertrophy. What do at first with that? We do ectomy. But if the patient has both the tonsils, the enlarged tonsils and the enlarged adenoids, you do adenotonsillectomy. You do of both. If it is only the adenoids, you remove the adenoids. If it is plus the tonsils, then we remove plus the tonsils. So next we will do pharyngitis. We do pharyngitis, then we do tonsillitis. The only difference between pharyngitis and tonsillitis, remember in pharyngitis, it is the mucous membrane that is involved. In tonsillitis, it is the tonsils that are inflamed, and the mucous membrane around the oropharynx is not inflamed. In tonsillitis, we have the So most of the time, pharyngitis follows viral infection. Viral, you are and it can be cold. So how does our patient? The presentation depends with the severity of the infection. At what stage did this patient reach you? Or did he just come when he's having the discomfort in the throat and some malaise? Pharyngitis. In tonsillitis is where we have the lymph nodes enlarged. In pharyngitis, it is just the pharynx that is congested. Then this patient now will have high fever. Then the patient will have headache. The patient can have dysphagia because of the irritation of the throat. We can have the cervical nodes involved. So our diagnosis is made through history taking and examining. Always advocate for swab for culture and sensitivity to see which microorganism is causing the recurrent pharyngitis or chronic pharyngitis. Then you will treat with an, you can advise the patient on rest. If it is a fungal one, you give antifungal. So in acute tonsillitis, we've said it affects the tonsils. It's acute infection of the tonsils. We have two palatine tonsils. When we open our mouth, you'll see walls tonsillectomy. Most common in adults are also, they also issues with the allergy. Remember, during the allergic process, we have also inflammation, and it can also involve the throat. They can still get tonsillitis. Patient presents, the patient will have sore throat. They'll tell you they have sore throat. They can have difficulty swallowing because of the inflamed and enlarged tonsils causing blockage. Then they can have fever. They can have, the infection can spread to involve the ears. And then they can also have the enlarged lymph nodes. And then when you examine the throat, you will find the tonsils are So we will give we'll advise for bed rest, we give antibiotics, we give analgesics. At times, tonsillitis does complicate. It can complicate to an abscess. Maybe you can have peritonsil abscess, we can have parapharyngeal abscess, and then it can also give us acute otitis media. All those give us the lead to acute otitis media. So next we will do laryngitis. Laryngitis now is infection in the larynx. Remember, is the so the most common microorganism can be Eza that follows up a URTI, a viral infection. So H influenza can follow that, or Staph aureus. So the non-infection type can be because of maybe voice abuse when we are shouting, we are straining to sing. And then can also be because of allergy. People with allergy, you find they have hoarseness of voice, or they're having pain, and then can also become maybe because of a chemical burn to the larynx, can still cause laryngitis that the patient will present. And then they have a dry, irritating cough that is always worse. And then they can have discomfort, the general symptoms like the headache, malaise, the fever. So treat laryngitis patient their voice, and if he's a frequent caller, he can stop and now start using, maybe sending texts or can inhale, or at times we even advise them to drink hot water like 3 times a day. Then if the infection is severe, you can laryngitis. So there's something that is also common in children. I did not make notes in it. Acute laryngotracheobronchitis, LTB. LTB is common in children. It's an inflammatory condition. It involves the larynx, the trachea, and the bronchus. Most commonly, it follows they often start with the upper respiratory tract symptoms like hoarseness and a croupy cough. They always have a croupy cough, and they have a very bad fever of around 39 to 40. And then they can also get, after that, the children may present with difficulty in breathing and an inspiratory stridor. And also, you can also even have that croupy cough, then they have the hoarseness, have difficulty in breathing, and then they can also have stridor. And the gradual, is the respiratory distress also progresses. So children with LTB have to hospitalize them. Then we give IV medication. We can give humidification, inflammation. So our last topic today, we will do dysphagia. Dysphagia is not passing. It is not swallowing is dysphagia. So food for the esophagus, and there are causes in the esophagus. So before the esophagus is something in the mouth, in the pharynx, and then we have now the esophagus. Anything that is affecting those regions can give us dysphagia. So the most common ones in those that affect in the mouth, it can give us issues with swallowing. It can give us difficulty in swallowing. Then maybe if someone has difficulty in chewing, maybe caused by trismus or fractures of the mandible, then the patient can have difficulty in swallowing. Then when we have anything that is affecting our saliva production, disturbance in lubrication. So most of the time follow xerostomia that occurs salivary glands, then we don't have enough. It helps to lubricate the food, and then in the mouth can give us is normal. For food to enter the pharynx, a normal one, the food enters. So anything that is affecting the opening of the esophagus towards the that is affecting food entering the pharynx, because from the pharynx the food is directed to the esophagus. Anything that is affecting that can give us dysphagia. So just the same as in the oral phase, maybe we can have lesions in the pharynx like tumors of the base of tongue, tumors of the soft palate, tumors of the pharynx can still give us obstruction in the pharynx. Even tumors in the larynx can cause pressure symptoms to the pharynx. Then when we have infections of anything in the pharynx like the tonsils, then we can have it affecting swallowing. When you have a peritonsillar abscess, it can affect swallowing. Then when we have like paralysis of the soft palate, still can affect swallowing, or paralysis in the larynx can affect swallowing. Then we have causes that are direct to the esophagus. So when you are thinking of causes in the esophagus, you still think of what can affect the lumen of the esophagus, what can cause obstruction from outside the esophagus. Maybe like a hiatus hernia can the pressure symptoms can give us obstruction in the esophagus. Then on the wall of the esophagus, when we have acute or chronic esophagitis, like even in patients who have GERD, they can have spasms of the esophagus, then they can get dysphagia. On the lumen, maybe you can have a foreign body esophagus, and then or tumors in the or in the lumen of the esophagus. They can still give us dysphagia. They can still cause obstruction of food when we are swallowing. So how does our patient, what investigations we do? These patients mostly they'll come to you and tell you, I try swallow food and it cannot pass. Nameza chakula haipiti. Ilianza na solid food maybe, and then it progressed to liquids. Most of the time it starts with the solid food and then later progresses to semi-solids and then to liquids. So we have to do a proper history taking. A detailed history taking is key to everything in our profession. So we have to do a detailed history taking. Here we'll have to know the onset. How is it progressing? Is it intermittent? If it is intermittent, maybe it can be because of spasms. And then is it more to solids or is it more to liquids? So if it is more to solids, then later it progresses to liquids, you can start thinking of a malignancy. And then is there intolerance to acidic foods? You can ask about that. That one can tell us maybe the patient has ulcerative lesions in the abdomen. And then you can also ask about regurgitation. Does the patient have heartburn? Remember, GERD can still also give us dysphagia. Does the patient have heartburn? Does the patient have regurgitation? And then is the regurgitation worse while lying down? You can ask the patient about his meal times. How many hours does it take post eating for him to lie down? To avoid regurgitation, you will advise the patient on that. Then you'll do clinical examination. Clinical examination, remember, we had courses in the oral phase, in the pharyngeal phase, in the esophageal phase. So when we are doing clinical examination, we have to examine our oral cavity. We examine our oropharynx. We examine even our neck. We examine the larynx, so that we are checking for where can the cause of this dysphagia be coming from. You also have to check our cranial nerves to check for any paralytic lesions. Then we have to do our blood examination. We do full hemogram or complete blood count in. You check if there's anything like the Plummer-Vinson syndromes in that causes anemia, and it's common in patients with CA larynx. And then you'll do radiography. Radiography, you can do an X-ray of the chest to rule out anything in the chest or in the heart. And then we'll have to do lateral neck X-ray to check whether we have is our cervical spine okay? Does it have osteophytes that is giving us pressure symptoms? And instead, you can also do endoscopy, barium. We can do barium swallow before endoscopy, or we can do esophagoscopy. So barium swallow is useful, especially in diagnosing malignancy. But these days we rush for endoscopy so that we check inside, and if it is a mass, then we take a biopsy for histology. So that is how we will investigate our patient with dysphagia. So management, you manage as per the course. I think I'm through for today. Anyone with a question? There were just few subtopics today. The main one today was the adenoid hypertrophy, of which you'll meet most of them in the outpatient or in the pediatric MCH, and then you refer to the ENT. And we've said the most common symptom is the snoring, mouth breathing, nasal blockage that they present with. Anyone with a question? Okay, if there is no question, I'm sending the notes right now so that I don't forget. I sent the other ones because I sent them a bit late. All the best. We will have 30 MCQs. Then we will have short answer questions, and then we have a long essay too. The short ones are 8 or 10. So that will be in the exam. I'll not give you a cut. We'll just wait for the main exam. All the best in your exams. And thank you.
Thank you. Thank you, and have a good night.